Today, we'll discuss about whooping cough or pertussis. Pertussis is also known as whooping cough, a violent cough, or the cough of 100 days. It's an acute infectious disease caused by bacteria Bordetella pertussis. It's a human disease and no animal or insect source or vector is known to exist. Recently, the cases are increasing globally, particularly in the United States, and CDC recommends vaccination and post-exposure antimicrobial prophylaxis to prevent pertussis. So this bacteria is a fastidious gram-negative coccobacillus, and human are the only reservoirs. Talking about the pathogenesis of this bacteria adheres to the respiratory epithelial cells, and it produces multiple antigenic and biologically active products like ethinylated cyclase toxin, pertractin, pertussis toxin, and these products are responsible for the clinical features of pertussis. So when this bacteria adheres to the ciliated respiratory epithelial cell and multiplies there, it can cause systemic intoxication because of the various toxins like pertussis toxin, ethinylated cyclase toxin, and other toxins. These toxins they lead to the local mucosal damage as well as are responsible for the paroxysmal cough as well. After this bacteria is attached to the respiratory epithelial cells, it can enter into the cell and can persist there, leading to the transmission as well. Similarly, this bacteria interacts with the immune effector cells and it helps in the survival of this bacteria within the macrophages. So this is the pathogenesis of the Bordetella pertussis. One of the important factors in the pathogenesis is the pertussis toxin. This toxin has multiple effects, like it disrupts the tight junctions, it promotes pulmonary hypertension, it inhibits lymphocyte homing to the lymph nodes and extravasation. It also reduces the number of the regulatory T cells, it suppresses antibody responses, it inhibits neutrophil recruitment and also induces chemokines and cytokines, and also inhibits the phagocytosis. Incubation period is usually 5 to 10 days, but sometimes it can be as long as 21 days. Transmission occurs from person to person through the respiratory droplets or through the airborne transmission, and it affects 100% of the non-immune household contacts, and the disease is highly contagious. People at risk include pregnant ladies, patients with epidemic exposure, those who are not immunized, those who are in close contact with an infected individuals. Clinical features can be divided into three stages: catarrhal stage, paroxysmal stage, and the convalescent stage. Catarrhal stage is characterized by the insidious onset and the symptoms are indistinguishable from the other respiratory tract infections like fever, fatigue, rhinorrhea, conjunctival injection. This stage lasts for around 1 to 2 weeks and it is the most infectious stage of the disease. This catarrhal stage is followed by the paroxysmal stage, which lasts for about 1 to 6 weeks. And during this stage, patient develops the paroxysms of the staccato cough, fever gets resolved, and then repeated coughs followed by the forceful inspiration can occur, which leads to the characteristic whoop. After this paroxysmal stage, then patient enters into the convalescent stage where the cough can persist for weeks to months, and it usually takes months to resolve. Differential diagnosis is broad. It includes viral upper respiratory tract infection, bronchiolitis, pneumonia, even tuberculosis, foreign body aspiration. In old patients, we need to consider acute exacerbation of COPD. And because of the lymphocytosis, we might need to rule out the leukemia as well. For the diagnosis, history is very important. We need to ask history about the close contact with a person with the confirmed pertussis. Duration of the symptom is also important. Like if the cough is persistent for more than 2 or 3 weeks, then it might be pertussis. However, if the symptoms are very short or has been lasting for less than 2 or 3 days, it could be just viral infection. We need to ask about the compatible symptoms like paroxysmal coughing, inspiratory whoop, post-tussive emesis, prolonged cough without other explanation, and we have to ask about the vaccination history. Leukocytosis with lymphocytosis is a characteristic feature, and sometimes leukocytosis can be up to the extent of 25,000 to 60,000 per ml. Chest X-ray might show non-specific changes like peribronchial thickening, atelectasis, or infiltrates. One of the features which has been associated with pertussis is the saggy right heart border. Culture is considered as the gold standard for the diagnosis. We can use the Bordetella agar or Regan-Loy agar. Cultures are typically not positive for 3 to 7 days, and overall sensitivity of the culture is only 20 to 40%. So Clinical diagnosis is more important than the diagnosis from the culture, because culture might take many days to come positive. PCR is the next method for the diagnosis, and it's more sensitive and specific than the culture, but this testing is not widely available, so we might need to again think clinically before treating the patient rather than relying just on the investigations. Serology also helps in the diagnosis of the patients. The preferred specimen for the culture and PCR is the nasopharyngeal swab or aspirate. This picture shows the optimal timing of the Pertussis diagnostic testing. Like for in the first 2 weeks of the symptoms, PCR and culture can be done. And if the symptom has been present for 2 to 4 weeks, PCR is the preferred test. And if symptom has been present for more than 4 weeks, serology is the preferred test. Talking about the treatment, ideally, treatment of the Pertussis should be started during the first 1 to 2 weeks before coughing paroxysms occur. Treatment is ineffective if it's started later in the course of the illness. Supportive treatment has a key role in the management, and some of the supportive treatment include oxygen, suctioning, hydration, avoidance of the respiratory irritants, and the parenteral nutrition if patient is unable to take orally because of the severe coughing episodes. Antibiotics have minimal effect on the duration or severity of the disease when they are started in the catarrhal phase, and there is no proven effectiveness when it's started in the paroxysmal phase. So the primary goal of using antibiotic is to decrease the carriers and the spread of the disease, and antibiotics are indicated if onset of the cough was within past 3 weeks. We can use many antibiotics. However, erythromycin and azithromycin are the preferred agents. Azithromycin is preferred to the erythromycin nowadays because of the ease of dosing and the fewer side effects. We can also use the clarithromycin, and if patient is allergic to the macrolides, we can go for the trimethoprim sulfamethoxazole. However, the efficacy of this drug is not yet proven. One thing we need to be careful is we should not prescribe macrolides to the infants less than 4 weeks old, because there has been incidence of increased infantile hypertrophic pyloric stenosis related to the macrolides. Other than antibiotics, corticosteroids is sometimes used in the critically ill patients, but the efficacy is not proven. If there is a severe leukocytosis with lymphocytosis, exchange blood transfusion therapy might be used. However, beta-2 agonists, Pertussis immunoglobulin, cough suppressants, and antihistamines are ineffective. Strict isolation is important in the management. Patients are contagious throughout the catarrhal phase in the first 3 weeks after the onset of the paroxysmal phase, so patients should be isolated during that period of time. And if patients are treated with the antibiotics, isolation should be continued for at least 5 days after initiating the treatment. Patient can develop complications related to the infection itself, or complications can arise because of the severe cough. So because of the infection itself, patient can develop secondary bacterial pneumonia, patient can develop otitis media, seizures, or encephalopathy. And because of the severe cough, patient can develop subconjunctival hemorrhage, periorbital edema, pneumothorax, pneumomediastinum, diaphragmatic rupture, umbilical inguinal hernias, and sometimes even the rectal prolapse. Most of the patients, they recover fully. Morbidity and mortality is higher in the infants, in the older adults. Infant death rate is around 2%. Prevention is very important because it can reduce the incidence of the pertussis. We can divide prevention into 3 strategies like vaccination, post-exposure antimicrobial prophylaxis, and the respiratory hygiene. First, we'll discuss about vaccination. CDC recommends pertussis vaccination in people of all ages. Acellular form is the preferred one because it has fewer adverse effects and the efficacy is similar to that of the whole cell formulation. This picture shows the recommendation for the whooping cough vaccine. So for the young children, vaccine is usually given at 2, 4, and 6 months of the age, and then from 15 through 18 months and from 4 through 6 years. And for the preteens, vaccine is usually given at 11 through 12 years, and for the adults, they can take the vaccine anytime for those who have not received it. Regarding the pregnancy, the vaccine can be administered during the 3rd trimester without harming the fetus. And this DTaP vaccine is approved during the last 3 months of the pregnancy to prevent the pertussis in the infants under the 2 months old. Immunity after vaccination usually wanes off significantly after the 7 years, and the natural infection provides immunity for 4 to 20 years. What we need to understand is the immunity after either infection or the vaccination is not lifelong. Post-exposure antimicrobial prophylaxis is given in the certain cases like those patients with household contacts of a pertussis case, people at high risk of developing severe pertussis infection like pregnancy, elderly patients, immunocompromised, and those who will have contact with the people at high risk of developing severe pertussis infection. So for all these recommendations, erythromycin is the recommended antibiotic, and usually this post-exposure antimicrobial prophylaxis is given within the 21 days of onset of cough in the index patient or within 21 days of the exposure. Respiratory hygiene is very important. Patients should cover their cough or sneeze. Frequent hand washing with soap and water is also effective in preventing the disease. At last, let's briefly talk about the epidemiology. So recently, there has been an increase in the cases of pertussis in the United States and throughout the globe. Worldwide, there are over 24 million cases annually with more than 160,000 deaths. This picture shows the incidence of the pertussis by age group from 1990 to 2022. This pertussis is a reportable condition in the US, so all the cases of pertussis should be reported to the public health authority. These are the references which we used while preparing our video. Thank you so much for watching. Please subscribe to our channel for more videos.